So we'll have only one lecture in this session, and that will be featuring Professor Geetha Subramanian, Senior Consultant Interventional Cardiologist from Chennai. Professor Subramanian to deliberate on coronary artery disease and women.
At the outset, I thank Professor Chopra and our most renowned, respected Dr. Parashar for giving me this opportunity to talk about this coronary artery disease in women. In fact, this is the topic which gets least attention. As such, coronary artery disease in women is given very much of little importance, and maybe the day has come when we have to take more care. Now, actually, what is the objective of this topic is to demystify the truths and examine the myths, risk factors, the diagnosis of CAD in women, and then HRT, what is now, what is the latest knowledge about it, then the bottom line and the current and the future research. The fact, cardiovascular disease, primarily CAD, outnumbers the next 16 causes of death in women combined, including all cancers. Women are 4 to 8 times more likely to die of CVD than of any other disease. CVD will be the leading cause of death for next 20 years in the developing world. Since 1980, the death from CVD has declined in men but increased in women. Now, the Canadian Cardiovascular Society states that the mortality presentation is twice that of men. It has only been in the last decade that there has been heightened awareness within the healthcare community that differences between men and women exist. Now, the cardiovascular mortality trends in men and women, if you look at it, the trend in men is towards a downward trend, and for women it is in the upward trend. And the percentage of total deaths due to CVD by age and sex, if you look at women at an age after 65, women outnumber men in the cardiovascular mortality. The risk factors for coronary artery disease in women, most important thing, like any other, the thing is diabetes increases CAD-related mortality in women 3 to 7 times more than in non-diabetic women. Increase of CAD-related mortality rate in men to 2 to 4 times. And diabetes is the greatest predictor of CAD for women than for men. And it reduces women's life expectancy advantage. Normally, we always feel women have got better advantage. In fact, you would have seen more grandmothers than grandfathers alive. Maybe the truth may not be so in future. And difference may be due to a particularly deleterious effect of diabetes on lipids and blood pressure in women. Now, this is just a small cartoon on dyslipidemia. I installed all new plumbing. I got tired of writing about my cholesterol. So that is the situation, because repeated stenting and this dyslipidemia playing a major role in actually the stent blockage as well as the progression of the disease. So dyslipidemia after the age of 50, the cholesterol levels in men plateaus. That's very important to note it. That it comes to a plateau, whereas levels of LDL increase an average of 0.05 mmol per liter per year between 40 to 60 in women. Part of this increase results from declining levels of estrogen. Decreasing estrogen results in the down-regulation of LDL receptor in the liver. A high LDL level is a strong predictor of coronary artery disease risk in women younger than 65 years and a somewhat weaker predictor in women more than 65 years. Low HDL level is a stronger predictor of CAD mortality in women than in men, particularly after the age of 65. Then we have got the FRAMINGHAM heart study, which says 8-year risk of heart disease was 7% for women with a total to HDL ratio of less than 5. 12% of those with ratios of 5 to 7 and 20% of those with greater than 7, the ratio greater than 7. Further, another study of 2,500 women aged 71 years or older, those with HDL levels less than 0.9 had a risk rate of CAD mortality, twice that of women with HDL levels of 1.6 or more. Elevated triglycerides is also shown to be a significant risk factor in women, especially when the HDL level is low. The Air Force Texas Coronary Atherosclerosis prevention study used drug intervention of the statin in men and women who had average total and LDL cholesterol levels and slightly low HDL levels. Reduction of primary CV events was demonstrated in both sexes. However, the US-Canadian prevention trial investigators found women especially continue to be undertreated compared to men. Then other risk factor is hypertension. Major trials of hypertension treatment like the hypertension detection follow-up program, systolic hypertension in the elderly have included adequate number of women and demonstrated benefits of treatment. Women with hypertension have fourfold risk of heart disease compared with normotensive women. Men with hypertension have a threefold increase in risk. Isolated systolic hypertension in older women has a 30% prevalence in women older than 65 years. Women with hypertension outnumber men with hypertension older age group due to survival advantage. Estimated prevalence of BP more than 140/90 in women older than 45 years, 60%. Then, smoking. What is the effect of smoking? Of course, we think of our women never smoke. But if you come to all the shopping complexes, you'll be alarmed to see proportion of women smoking is more than men. So smoking is going to be one of the great risk factors in India in future. So the doctor says here, I'm prescribing a patch just to keep it shut over your mouth so that you don't smoke. Smoking, the leading preventable cause of coronary artery disease in women is cigarette smoking in worldwide. More than 60% of MI in women younger than 50 years can be attributed to tobacco use. 21% of all CAD deaths attributable to smoking. The risk in heavy smokers is 2 to 4 times higher than in non-smokers. Light smokers, that is 1 to 4 cigarettes per day, have double the risk of non-smokers. Stopping smoking decreases the risk of CAD within months. Nurses' Health Study found the risk of CAD decreased by 1/3 2 years after cessation. The prevalence of smoking recently has dropped both in men and women. However, women's rate of cessation is lower than that of men. Almost 1/4 of women smoke cigarettes. Greatest increased prevalence of smoking in women ages 65 years or older. Of course, this is not pertaining to our country, but since the World Congress, I can talk about the world. And this is actually, people never smoke, and what is the proportion of smoke? As age advances, there is an increase in the smoking habits. Then menopause. Natural menopause confers a threefold increase in CAD risk. But in the present day world, with the premature menopause, due to stressful life, as well as premature hysterectomy and oophorectomy, I think there is a greater risk of coronary artery disease. Added to this is the abdominal obesity and the apple obesity, which contributes also to a greater incidence of coronary artery disease. The Nurses' Health Study cohort showed that women undergoing bilateral oophorectomy had up to 8-fold increased risk of CAD. Of interest, the Nurses' Health Study showed that early natural menopause was not a risk factor for CAD after adjustment for tobacco exposure. Degree to which estrogen deficiency increased risk of CAD remains a subject of debate. Many studies have found the incidence of CAD in postmenopausal women higher than premenopausal women of the same age group. Although the largest increase in coronary mortality coincides with menopause, vital statistics do not support the menopause apart from chronological aging increases risk of CAD. So the risk seems to be more because of the aging rather than due to menopause. Effect of aging versus estrogen deficiency versus lipid increase. What happens? So the next thing is obesity and the physical activity. In the modern world, with increased tendency for overeating everywhere with couch potato lifestyle, obesity has come to stay as a very big risk factor. Less physical activity and more obesity. So, that too in a multitasking woman. This woman says, I'm a mother, I'm a wife, I'm a businesswoman, I'm a teacher, I'm a nurse, I'm a cook, and a housekeeper, and a housekeeper, and then just 23 pounds per woman. So, this is the only person, probably the only person blessed with obesity, which is a boon rather bane, and who continues to wish and be happy about it, maybe only Lord Vinayaka. And except him, I don't think anybody in the universe can consider obesity as a virtue. Obesity, both men and women, has been increasing over the past few decades. Obesity and sedentary lifestyle are interrelated. It is an independent risk factor for all-cause mortality and associated with diabetes, hyperlipidemia, and hypertension. So, when you look at obesity in men and women, as age advances, we find there is a progressive increase in the obesity, both men and women. Now, what is the contribution? 30.5% of Canadians between the age of, this is a Canadian study, 20 to 64 are obese with a BMI of more than 27. Obesity is the most common metabolic condition in industrialized nations. Total direct cost of obesity was estimated to be nearly about $1.8 billion. So in a country like India, where the population is so high, then you can imagine the contribution of obesity. That too, our bane has been the syndrome X, with insulin resistance and diabetes, triglycerides, low HDL. So, the doctor prescribes him where to exercise more. Then, physical inactivity contributes to obesity, an independent risk factor for MI. Investigators, nurses health study found 30 to 45 minutes of walking 3 times weekly reduces the risk of MI by 50%, even in older women. It is estimated between 39 and 54% of the North American women do not get adequate physical activity. Of course, we do not have proper statistics in our country. Maybe we may come out with that next year. Exercise has been found to reduce the risk of type 2 diabetes even in women with obesity. HDL level has shown a dose-response relationship in female runners. The diagnosis of CAD in women. So, approach to diagnose, the perception persists. CAD mainly affects men, not a serious concern for women. Women develop angina about 10 years later and a first MI about 20 years later than men. Women are more likely to have angina than MI as the initial presentation. These are all these imaginations or probably this thing about the women. Women tend to have more atypical features. Men present with CAD than men, which is very true. And then women present with acute MI tend to be older and have more comorbidity. And women are less likely than men to attribute their symptoms of cardiac disease, even in the setting of acute MI. So they tend to be always a denial mode. And that too, when there is a typical chest pain or no chest pain, naturally they have got a chance of dying more in the first attack. Estimating the risk in women by the assessment of patient clinical characteristics and coronary risk factors more easily and accurately accomplished in men than women, and as the prevalence of CAD is lower in women than men, except older women, the predictive value of any symptom or non-invasive test is lower in women. So the nature is also against women. Not only the human beings, but nature is against women. The presence of any type of chest pain, whether atypical or typical, is associated with a lower risk of CAD in premenopausal women. And then the likelihood of CAD increases after menopause. Diabetes eliminates the age advantage in women over men and confers a substantially greater CAD mortality than in non-diabetic women. Diabetes is an important predictor of the presence of CAD in women. Diagnostic evaluation, for the purpose of performing a clinical evaluation, is to identify those at very high risk who would benefit from immediate coronary angiography and lower risk patient to accurately identify those with significant CAD prior to development of acute event. Patient can be classified into high, intermediate, low probability by taking into consideration factors such as chest pain types, typical, atypical, non-ischemic, then determinants, major, intermediate, minor, or the likelihood of the CAD. So classification of chest pain, typical angina, substernal, squeezing, burning, heavy, exertional, precipitated by emotion, promptly relieved by rest and nitroglycerin. So class 60 to 70% prevalence of angiography. These sort of people have 60 to 70% prevalence of angiographically proven CAD. Then left-sided chest pain, atypical, abdominal pain, back pain, arm pain without mid-chest pain, sharp or fleeting pain, unrelated to exercise, relieved by antacids, 30 to 40% of angiographically proven CAD. Now, determinants of likelihood of CAD women, major, postmenopausal status, age above 65 years, diabetes, peripheral vascular disease, intermediate, hypertension, smoking, lipid abnormalities, minor, obesity, sedentary lifestyle, family history of CAD and other risk factors of CAD. So classification is done according to probability of CAD. High probability, more than 80%, typical angina and any of postmenopausal status or age above 65, diabetes, peripheral vascular disease are two intermediate determinants. And then high probability of CAD, again continuing, 80%, atypical angina, any of the postmenopausal or age above 65, more than one intermediate determinant, diabetes plus more than one intermediate or minor determinants, 3 intermediate or 2 intermediate plus 1 minor determinants, and then intermediate probability 20 to 80%. Typical angina, 1 intermediate or 2 minor determinants, more than 2 minor determinants, atypical angina, postmenopausal, age above 65, non-ischemic pain. These are all the groups. That is first group, typical angina, intermediate, then atypical angina, postmenopausal age. The third group is non-ischemic pain, postmenopausal, age above 65, or diabetes, and more than 2 intermediate or minor determinants. So low probability, less than 20%. This group is typical angina, premenopausal, no determinants. Atypical angina, no major determinants. And third group is non-ischemic pain, no major determinants. So diagnostic testing. The prevalence of CAD, particularly multivessel disease, is lower than in men, except in the older age group. As a result, predictive value of any symptom or non-invasive test is lower in women than in men. Utility of diagnostic testing is related to the pretest probability of the disease. Therefore, it is necessary to make a careful assessment of risk in order to guide the choice of diagnostic modality or determine if the test is at all required at all. So diagnostic evaluation of low probability no tests, likelihood of false positive tests are greater than the likelihood of true positive tests. If negative, no further workup. High negative predictive value if inconclusive of baseline ECG shows abnormalities, or the goal is to localize and quantify ischemia, then go on to stress imaging studies. Then high probability stress testing or coronary angiography, depending upon the severity and stability of the symptoms. If negative stress tests may follow closely and observe. It's still controversial. If inconclusive stress tests, straight away go for angiography. Then HRT. What is new in?
I'm sorry for the interruption, Professor.
Okay. What is new? The numerous observational studies, including meta-analysis of more than 30 observational studies, showed reduction up to 60% risk of major coronary event in healthy current estrogen users compared to women who never used estrogen. In the first large randomized trial of HRT in women, that the Hearst trial found there was no significant difference in the combined incidence of CHD, that is death and non-fatal MI at 5 years. There was a mean reduction in LDL levels of 11%, an increase in HDL. However, there was also an increase in primary coronary events in year 1. Increased risk of a second CV event in the first year of the treatment, followed by non-significant reduction in the risk in the last 2 years, based on no cardiovascular benefit and a pattern of early increased risk of CAD. Investigators do not recommend HRT for secondary prevention. Extended follow-up of the Hearst cohort is underway. A second large randomized trial, the ERA study, also observed no benefit. The Women's Health Initiative is a 9-year primary prevention study with 27,000 post-menopausal women on treatment with placebo, and this trial is placebo as well as the drugs. This trial is scheduled for completion in 2005. The Women's Health Initiative study stopped the treatment arm of the study in 2002. The overall health risk exceeded the benefits from the use of this HRT, and the investigators therefore concluded that this regime should not be initiated and continued for primary prevention.
Sorry for the interruption.
Okay, it's over, sir. The HRT is for extreme perimenopausal symptoms is indicated, and is also for the prevention of bone loss and to decrease the risk of factor, and should not be initiated or continued for sole purpose of primary or secondary prevention of CAD. So we say men are from Mars, women are from Venus. So what are we doing about it? The investigators from Prevent 2000 published observational data citing that both the US and Canada treated hyperlipidemia inadequately, especially in women. Cox et al. Published a cross-sectional survey showing women are less likely than men to have a recording of BMI, smoking, BP, cholesterol profile, and less likely to be on lipid-lowering therapy in aspirin. The myocardial infarction triage and interventions registry as well as the TIMI-9 trial both identified that women with identical symptoms and profile were less likely to be admitted to CCU and its equivalent, therefore less likely to receive thrombolytic therapy. And Lee et al. Reviewed in acute coronary syndrome, found that age exclusion was declined from 58% to 40%, comparing trials from 1966 to 1990 and 1990 to 91 to 2000, and enrollment of women has risen from 20% to 25%, even though proportion of women with MI is 43%. Though more number of people are involved, less number of people are involved in the studies. Recent surveys of cardiac rehabilitation programs continue to underrepresent women, impacting secondary prevention, risk factor modification management. Bottom line, what is different for women? Presentation, present at later date. Typical angina is less predictive of CAD. pretest probability 50 to 60% compared to 80 to 99% despite typical symptoms. Women often present shoulder or jaw pain, dyspnea or nausea. Risk factors like diabetes, hypertension have a stronger influence in women. High HDL level is more common in women. Roles of total cholesterol in LDL women remains unclear. Risk increases after menopause. So, then prognosis, women are more likely to die of first MI. Overall case fatality rate of 32% women and 27% in men as per FRAMINGHAM data. 30-day and 1-year crude mortality rates are approximately double than that in women, than that in men. So double the mortality. Women have more comorbidity and experience more long-term disability. And primary prevention, initial evidence for the benefit of lipid lowering in women exists, but more evidence is required. Strong evidence to support adequate BP control, lifestyle. Secondary prevention, women are less likely to undergo angioplasty or bypass surgery. Fewer women receive cardiac rehabilitation. Fewer women receive therapy with aspirin, beta blockers, AC inhibitors. So current and future research, since difficulties in diagnosing in CAD in the women on the basis of chest pain and non-invasive testing may contribute to the lower referral rates for catheterization, revascularization, it is important to improve symptom evaluation and diagnosis of ISD in women. The women ischemia syndrome evaluation is ongoing, attempting to add to the limited information about the pathophysiology of ischemia without substantial epicardial coronary disease. They have more of small vessel disease, more of vessel instability, vascular instability, more of the small vessels are more involved than the epicardial. So naturally, it is very difficult to evaluate them. The Women's Health Initiative Study Group is looking at the strategies to prevent and control the most common cause of morbidity and mortality among post-menopausal women. It will continue to evaluate 3 interventions, namely low-fat diet, HRT, calcium and vitamin D supplementations. Then the beyond endorsed lipid levels evaluation study is currently recruiting post-menopausal women and will compare the effects of 12 months of atorvastatin or regression of coronary disease and give us an idea of if there is a gender difference. So conclusion. Despite the abundant evidence, CAD is virtually epidemic in older women. The belief that women have innate protection is still prevailing. So there is an epidemic. Even in the face of considerable mortality and morbidity rates, prevention and treatment are still less aggressive for women than men. Control of CAD risk factors will continue require recognition of differences as well as the similarities between men and women, the manifestation risk factors. Initial data suggests women can substantially benefit from lipid lowering drugs if diet and exercise fail. And then statins have proved particularly effective in lowering women's risk of coronary artery disease. Estrogen HRT to reduce risk have been popular in the past, but not now. It is not recommended for prevention of CVD. On the basis of HERS and ERAS trials, statin drug should be the drug of first choice for women with established CAD. Population of older women can be expected to increase in the coming decades, and a growing health problem will ensue if clinical issues are not properly addressed. In the words of Professor Henry Higgins in My Fair Lady, why can't a woman be more like a man? And why can't a man be more like a woman? So this was the last year we had a walk for a hot day at Agra in the Eco Park behind Taj Mahal. I addressed 500 school children. I only told them one word. Your heart is pumping blood for 10 lakh kilometers every day. Why don't you walk 2 kilometers a day to school and reduce the petrol cost and improve the foreign exchange reserve of the country? So that was why I would like to say this is the age, that is adolescent age, we should start teaching the children to protect their heart. These are the children who got really enlightened that day. They said hereafter we'll never go for pizza, we'll go for only for Deshi food and Deshi transport, including bicycle. With this I conclude my talk. If it was little lengthy, I request the pardon of our great professor to pardon me.
Thank you very much, Professor Subramanian. Please have your seat.
Thank you very much, Dr. Geetha. Please come and join us.
We have one more lecture coming up.
That was an excellent and extensive and a very lucid presentation. Hearty congratulations. And I would like to add one more point. Not only the presentation, even the management, there is a difference between men and women. The coronaries are smaller and more branch lesions. And the bypass surgery results are also poor in women, not only the angioplasty.